Hello everyone, thank you for joining us this evening for one of the Raymond A. Wood Foundation's monthly learning series events. This month we'll be learning about the role of oxytocin in hypothalamic obesity. I'm Dean Carson, I'm a neuroscientist and translational pharmacologist and a member of the Raymond A. Wood Foundation's Board of Directors. I'm joined here by my friend and colleague Eugenie Shu. Eugenie?
Hi, thanks Dean. My name is Eugenie Shu. I'm also on the board of the Raymond A. Wood Foundation. And I have a special interest in the topic because my son had a craniopharyngioma, and I did an experimental treatment using oxytocin and wrote about it in a blog called Hope for HO. I'm happy to be here. I want to also say thank you very much to our sponsor, which is Harbor Compounding Pharmacy. You'll hear a little bit more from them at the end. I just want to say that they have kindly decided to be our sponsor, and they happen to be the pharmacy that compounds my son's oxytocin. Thank you.
Thanks, Eugenie. Now we've got three speakers, and our first speaker is Dr. Ernie Blevins. Dr. Blevins is currently a research associate professor in the Department of Medicine in the Division of Metabolism, Endocrinology and Nutrition at the University of Washington. Over to you, Ernie.
Thank you, Dean. I'd like to start off by just thanking the meeting organizers, Dean, Amy, and Eugenie, for inviting me to talk today and share our data. Before I get to the question of whether an oxytocin acts as an anti-obesity agent, how it does so, I'd like to give you some background in terms of how we became interested in oxytocin as this potential weight loss therapeutic in the first place. And we know that in individuals that gain adiposity, the adiposity signal leptin circulation proportion of body fat. And this is particularly evident in periods of positive energy balance. In lean individuals in particular, leptin is able to signal to the brain to activate specific CNS circuits, resulting in a suppression of food intake and an elevation of energy expenditure to normalize energy balance. However, in states of diet-induced obesity in rodent models or in common forms of obesity in humans, the ability of leptin to activate specific CNS circuits is impaired. This is a phenomenon known as leptin resistance. This basically is characterized by an inability of leptin to reduce food intake and also potentially increase energy expenditure, the net result being an inability of leptin to reduce body weight. And so we and others have identified oxytocin as being a downstream target within the brain of leptin signaling. And so we've used oxytocin more or less as a therapeutic strategy to circumvent leptin resistance and to reduce food intake and elevate energy expenditure to reduce body weight in situations where the ability of leptin to do so may be compromised. And so here's a schematic showing a sagittal or a side view of a rodent brain, and it illustrates some of the circuitry thought to contribute to the ability of leptin to reduce food intake. I mainly want to point out to you that leptin is thought to act at least in part within the structure of the brain called the hypothalamus, which is linked to the control of food intake and body weight. And one of the structures within the hypothalamus is an area called the PVN, or the paraventricular nucleus. And this sends downstream relays to areas of the hindbrain that respond to meal termination signals, otherwise known as satiety signals, such as CCK and gastric distension. And we and others over the years have generated evidence implicating oxytocin as an important mediator in this pathway. We know that oxytocin not only is produced in the PVN, but it sends projections directly to the hindbrain. And this projection is thought to contribute to the ability of leptin to communicate with hindbrain signals, resulting in the suppression of food intake, mainly through reduction in meal size. So oxytocin receptors are not only thought to be relevant here in the control of food intake, but more recently, we and others have proposed that oxytocin receptors may also be relevant in the control of metabolic energy expenditure, namely through the activation of brown adipose tissue. I won't get into too much of this today, but this is an ongoing research focus of my laboratory. And you're already familiar with oxytocin's effects on reproductive behavior and pair bonding, but there's other aspects of oxytocin that can influence body weight regulation, namely its ability to stimulate lipolysis as well as energy expenditure. And on the flip side, it can also reduce carbohydrate consumption as well as fat intake, and as well as delay gastric emptying, all of which contribute to its effects on body weight. So here's some evidence from early rodent studies really implicating a potentially important role for physiological oxytocin in the control of body weight. Camarino and Takayanagi's work really illustrated a nice effect of physiological oxytocin, and namely by revealing that mice that lack oxytocin or its receptor are associated with adult onset obesity. And then similarly, Dongxin Kai's work has shown that either pharmacological blockade or viral deletion of oxytocin neurons within the paraventricular nucleus are associated with elevated food intake, reductions in energy expenditure, as well as weight gain. And more relevant to the talk we're giving today is that exogenous oxytocin administration has been found to reduce food intake as well as elicit weight loss in diet-induced obese rodents, non-human primates, and obese humans. And you'll be hearing more about the human work from Liz's work as well as Jennifer's work a little bit later on in the session. So these findings have led us to hypothesize that oxytocin action within the brain is able to evoke sustained weight loss by reducing energy intake and stimulating energy expenditure. So the question to test this hypothesis was whether or not chronic CNS administration of oxytocin can elicit weight loss in animals with established diet-induced obesity. So in order to establish diet-induced obesity, we maintained rodents on the high-fat diet for approximately 4 months prior to implanting them with brain cannulas and 28-day mini pumps, which are basically able to deliver the oxytocin directly into the brain. And the mice received oxytocin or vehicle. And then we measured daily food intake, body weight, as well as body composition to really get at fat mass versus lean mass. And this graph shown here on the left illustrates the effects of oxytocin over the 28-day period, shown here in yellow in relation to vehicle-treated animals, shown here in green. Is what you can see is that there's an early reduction in body weight, which is basically maintained throughout the entire infusion period. And the next question we asked was whether or not these effects are associated with reductions in fat mass. Here we saw that oxytocin is able to induce a profound effect to reduce fat mass. And I think this is important because we find a more of a specific or a selective effect of oxytocin to reduce fat mass while it actually spares lean mass. I think this is important because some of the weight loss agents such as topiramate are associated also with reductions in fat mass, but at the expense of also reducing lean mass. And then next we asked whether or not these effects are attributed to reductions in food intake. As you can see, oxytocin, again shown here in yellow, is able to reduce food intake, although the data are somewhat noisy at times. Typically we see this effect usually occur throughout the first, second, or third week of the infusion period. And I think it's important to point out that the feeding effects do appear to wane after about the second or third week of the infusion period, suggesting that other mechanisms may also be important, such as increased energy expenditure. So we've found, and as well as others have found, that oxytocin can elevate energy expenditure in rodent models. This is work done by Dongxin Kai, where he showed that oxytocin is able to elevate oxygen consumption when animals are placed in metabolic cages. And he showed this was true of both lean mice as well as diet-induced obese, high-fat diet-fed mice. And then Emily Noble's group came a few years later and showed that this was also the case in lean rat models. And so to summarize the rodent part of the talk, we've shown that the collective studies indicate that central administration of oxytocin is able to reduce body weight as well as body adiposity in diet-induced obese rodents, in part by reducing energy intake and also increasing energy expenditure. So having established that the central administration works in the rodent model, we then ask the question of whether or not systemic or peripheral administration can recapitulate these effects as a proof of principle in a more translational non-human primate rhesus monkey model of diet-induced obesity. So we used adult male rhesus monkeys from the UC Davis California National Primate Research Center in collaboration with Peter Havel. And he has an established model of diet-induced obesity where the animals are actually maintained on a sugar-sweetened beverage. And basically, in contrast to what we showed with the diet-induced obese animal models, these animals are on sugar and not a high-fat diet, but both approaches or dietary approaches will actually result in diet-induced obesity. These animals were individually housed and then adapted to a 12-hour overnight fast. And here quickly is the paradigm. Animals were accustomed to twice daily injections. In the first week, basically animals received saline or vehicle, which was the carrier that we used for the oxytocin. And then at 7 o'clock and 3 o'clock, animals got access to chow as well as Kool-Aid. The chow was replaced again in the afternoon. And then they quantified food intake in the afternoon as well as the early evening. And animals were fasted again in the early evening. And then we obtained once weekly body weight at the same time every week. And so using a dose escalation model, we looked at the low dose of oxytocin. Basically, everything was the same as what we did with the vehicle treatment, except we replaced the vehicle with the low dose of oxytocin. Again, animals received injections twice daily. I want to point out that these injections were directly, they were subcutaneous injections. And we had already shown in our previous studies, as well as others, that peripheral treatment can elicit some of the same effects we see following central treatment in rodent models. And then subsequent 2-week period, we looked at a slightly higher dose of oxytocin. And then we looked at a 7-week washout period where basically animals were just left untreated, but we still measured food intake during the first 2 weeks and the weekly body weight thereafter. And the data shown on this next slide, you can see that as expected, vehicle treatment was associated with a slight elevation of body weight. During the first week of the low dose, there was a slight reduction of body weight. This was more pronounced following the second week of the low dose. And then going to a slightly higher dose over the 3rd week of treatment, we're able to maintain the weight loss. And this was further pronounced in response to the 2nd week of the high dose. And so overall, the animals lost about 3.3, 3.4% body weight. This is pretty similar to what Dongshin Kai had shown after about the 4-week treatment period in obese and overweight humans. And also similar to what Kevin Grove's group had shown at Oregon Health Sciences University when they looked at melanocortin-4 receptor agonists in obese rhesus monkeys. And so to summarize, we've shown now that chronic peripheral administration of oxytocin is able to elicit weight loss in diet-induced obese non-human primates. And the next question is whether or not these effects are attributed to reductions in food intake and or elevations of energy expenditure. So we looked at cumulative food intake shown here. These are standard monkey chow pellets. And we can see that in response to, we looked at both 8 and 12-hour cumulative food intake. And we can see that the high dose was associated with a reduction in chow consumption over the 8-hour period. And then both doses were effective at reducing monkey chow intake over the 8 and 12-hour periods. And we looked at Kool-Aid consumption. Again, similar to what we saw with chow intake, oxytocin was able to reduce Kool-Aid consumption at the 8-hour time point, as well as there was a trend for doing so also at the 12-hour time point. And so these findings are consistent with what we found, or what others have reported following oxytocin administration directly into the brain in terms of reducing sucrose consumption, and also consistent with what others have shown with the oxytocin knockout mice who typically overconsume sucrose solutions. And we looked at energy expenditure. We also found that oxytocin, again, using indirect calorimetry chambers, we looked at baseline energy expenditure versus the end of the 2nd week of the high dose energy expenditure in response to oxytocin. We found that oxytocin was able to elevate energy expenditure, particularly during the dark cycle. We'll have to keep in mind that the dark cycle energy expenditure is closer to when they obtained or received that 2nd injection. And so these findings overall provide evidence that chronic oxytocin treatment can elicit weight loss in both DIO rodents and diet-induced obese non-human primates, through reductions in food intake as well as increases in energy expenditure. And these findings provide key translational data to support the use of oxytocin either given alone or as a treatment adjunct to other anti-obesity therapies in both diet-induced obese human primates as well as obese humans. And I'd like to thank my collaborators at the University of Washington, as well as the VA Metabolic Phenotyping Core and my collaborators that helped with some aspects of the non-human primate work at UC Davis, as well as my funding through the Pilot Award at UC Davis and the NIH and VA.
Amazing. Thank you so much, Dr. Blevins. Our next speaker is Dr. Elizabeth Lawson. Dr. Lawson is a practicing endocrinologist in the Neuroendocrine and Pituitary Clinical Center and director of the Interdisciplinary Oxytocin Research Program in the Neuroendocrine Unit at Mass General Hospital. And she's also an associate professor of medicine at Harvard Medical School. Go ahead when you're ready, Liz.
Thank you so much. Thank you for the opportunity to talk today about our research on the effects of oxytocin on eating behavior and metabolism in humans. In terms of disclosures, I'm on the Scientific Advisory Board and have a financial interest in Oxytocin Therapeutics, and this has been reviewed and is managed by Massachusetts General Hospital. So Dr. Blevins beautifully described studies in animals showing that administration of oxytocin results in reduced food intake and weight loss. And this led us and other investigators to ask the question of whether oxytocin could be used therapeutically in humans to reduce caloric intake and weight. And intranasal oxytocin is an investigational drug that can be used to answer this question. Weight loss was achieved in a small 8-week study of intranasal oxytocin in 20 men and women with obesity, 9 of whom received oxytocin, though the effect of oxytocin on eating behavior was not assessed in this study. So the first question that we asked is whether oxytocin reduces caloric intake in men as it does in animal models. We studied 25 healthy non-diabetic men across the weight spectrum, and we gave them oxytocin nasal spray, a single dose of 24 international units at 1 visit, and placebo, which includes the same inactive ingredients but no oxytocin, at another visit, the order of which was determined by chance or randomization. After receiving oxytocin or placebo, participants were given double portions of a breakfast meal that they had previously ordered from a menu, and the caloric intake was then calculated. Consistent with what Ernie has described in animal models, a single dose of intranasal oxytocin reduced total caloric intake, with a preferential effect in reducing the consumption of fat. Oxytocin also increased fat burning and improved insulin sensitivity, or how the body handles sugar, and it was well tolerated. So the next question that we asked is, how does oxytocin modulate eating behavior? So I'd like to just take a moment to give you an overview of how I think about the regulation of eating behavior. Homeostatic or energy balance pathways signal the availability of nutrients in the gastrointestinal tract and energy stored as body fat. And these signals are then integrated by the brain along with other incoming messages, for example, from reward-related food motivation and impulse control pathways, ultimately leading to decisions about eating. So if you were to offer me a donut right now, my homeostatic system would recognize that I just had dinner. There are plenty of nutrients available, my energy stores are adequate, so from an energy balance or homeostatic standpoint, there's no need for me to eat the donut. But I'm going to eat the donut, and that's because I love donuts. I know that I'm going to find it rewarding to eat the donut, and right now I just don't have the impulse control to resist that temptation. So clearly there's more to eating behavior than simply homeostasis, and reward-related food motivation and impulse control pathways are critical for these kinds of decisions. So we hypothesized, based on animal data as well as the distribution of receptors for oxytocin in the brain, that oxytocin may reduce food intake by targeting all 3 of these pathways, making food seem less rewarding, improving one's ability to control the impulse to eat, and reducing homeostatic hunger. So to begin to answer this question, we studied 10 healthy non-diabetic men with overweight and obesity. Again, we gave participants a single dose of 24 international units of intranasal oxytocin at 1 visit and placebo at a 2nd visit, the order of which was determined by chance. This time we assessed brain activation using functional MRI while participants looked at pictures of food images. And we also assessed impulse control using a behavioral computerized test called the stop signal task, which has previously been linked to eating behavior. Now, since oxytocin reduces the intake of palatable foods, our primary hypothesis was that oxytocin would reduce activation in the ventral tegmental area, or VTA, which is the origin of the reward system. And as you can see here, a single dose of intranasal oxytocin reduced activation of the VTA when participants looked at pictures of foods. When we looked across the whole brain, we found that oxytocin broadly impacted regions that are involved in eating behaviors. So in addition to reducing activation of the ventral tegmental area, oxytocin reduced activation of all of these other regions that are important for reward-related food motivation, as well as the hypothalamus, which is important for the homeostatic control of food intake. In contrast, oxytocin increased the activation of areas of the brain involved in impulse control when participants looked at pictures of foods. Furthermore, using the stop signal computerized behavioral task, we showed that oxytocin reduced impulsive behavior. So taken together, these data suggest that oxytocin may reduce food intake by modulating food motivation and impulse control circuitry. So maybe if I had a dose of oxytocin before being offered this plate of donuts, I would say no, because I would sense less of a homeostatic need to eat. I would think the donut's less rewarding, and I would have a better ability to resist the temptation or impulse to eat. We now have 2 randomized placebo-controlled trials of intranasal oxytocin, 24 international units before meals and at bedtime, as a weight loss therapeutic. The first is a study of 8 weeks of intranasal oxytocin in men and women with obesity, which is almost finished. And the second is a 12-week study of intranasal oxytocin in adolescents with obesity, which we are just starting up. And I'd just like to mention that there's also an ongoing study of intranasal oxytocin for weight loss in adolescents and in young adults who have tumor-induced hypothalamic obesity, and that's led by Shana McCormick at the Children's Hospital of Philadelphia. And my understanding is that that is nearing the end and results should be available soon. So to summarize, oxytocin is under active investigation as an anti-obesity agent in humans, and preliminary studies show that intranasal oxytocin reduces caloric intake in humans, and the potential mechanisms include through reduction of homeostatic or energy balance, as well as reward-driven eating behavior and improvement in impulse control. Complementary metabolic benefits may include increased fat burning and improved handling of blood glucose, and studies are underway to determine whether intranasal oxytocin is safe and effective for weight loss in adults and youth with obesity, including those with hypothalamic obesity. So thank you very much.
Thank you so much, Dr. Lawson. Our final speaker is Dr. Miller. Before I introduce Dr. Miller, I want to just remind everyone that we do have a Q&A session after the speakers do their talks. So I encourage you all to ask your questions. Please do not put them in the chat, but put them in the Q&A little signal down there. And then Dean and I will be fielding the questions as we see them coming in. But the sooner you have them in, the better. So thanks for doing that. So for our last speaker, I'm happy to introduce Dr. Jennifer Miller. Jen Miller is a professor as well as a pediatric endocrinologist at the University of Florida in Gainesville. And she's quite famous for being, she really is famous, for being the champion for Prader-Willi syndrome. And treating the kids and being such a great doctor there. So I'm happy to introduce her, and also want to mention that she is the one who was my advisor for when I treated my son experimentally with oxytocin. So very appreciative of Jen.
Thank you. Thank you. That was a very wonderful introduction. Thank you so much.
You're welcome.
All right, let's see. All right, so I was tasked with, after those great and wonderful scientific talks, to talk to you about my clinical and research experience with oxytocin. So as Eugenie mentioned, I work a lot with Prader-Willi syndrome. I've also been working a lot with the craniopharyngioma community on this issue of oxytocin for appetite and weight regulation. And one of my biggest, areas of concern is actually the hyperphagia. So you heard about the weight loss effects and you heard about the body composition effects and metabolism, but hyperphagia is very difficult to define. We always say you know it when you see it, but it's this just insatiable, unrelenting desire to get to food. And that is what ruins the lives of a lot of people with Prader-Willi syndrome, with craniopharyngiomas, with astrocytomas. So I have been looking at oxytocin in the light of whether or not it can reduce that appetite drive. And the appetite drive, as you heard from Ernie at the beginning, is a result of the hypothalamus not being able to sense energy sufficiency. So it can't sense the fact that you've got enough body fat and that you don't need to eat. And so not only can you not sense that, but you also can't sense that you've eaten and should feel full. So theoretically, oxytocin, as you've heard, should work to help with both of these things, which should then help decrease the appetite drive or the hyperphagia. And, most individuals with hyperphagia develop obesity because they're starving, but you can have people that have hyperphagia that also have really good weight control because their families have extreme environmental control. The kitchen is locked, the refrigerator is locked. So, but because of everything you've just heard about, oxytocin is being researched for hyperphagia, and the majority of studies have been done in Prader-Willi syndrome, and so those are the great majority of what I'm going to talk to you about today. So Prader-Willi syndrome is a genetic condition which has been very well studied for treatments for hyperphagia because the hyperphagia is fairly ubiquitous in the population after childhood. So it begins in sort of later childhood, around 8 or 9 years of age, and continues through adolescence and through their entire lives into adulthood. Interestingly, when babies with Prader-Willi syndrome are born, they don't want to eat. They don't suckle. They don't open their mouth for food. They close their mouth and tongue out a bottle. And so you have to feed them either with an NG tube or a G tube in order to get them to survive. Otherwise, they would starve to death because they literally have no interest in eating, which is what I've always found fascinating about the syndrome, how it switches. So oxytocin has been studied in Prader-Willi syndrome for both of these aspects, both for encouraging and improving feeding in the infants and then decreasing feeding in the adolescents and adults. And so here is just a picture of people with Prader-Willi syndrome, and you can see that for the infants, the idea is that because they have poor interactions with their mother, lack of interest in food, that they would have, hopefully with oxytocin administration, normalization of food intake, and better communication with their parents. And then for the adults, there are a lot of features that oxytocin theoretically could target, including the hyperphagia, as I mentioned, but they've also got autism-like characteristics, which oxytocin is being studied for. They've got anxiety, they've got emotional lability. And so the idea is that with oxytocin in the older individual with Prader-Willi, that you would decrease their appetite, you would decrease their anxiety, you would increase their trust in others. And so I'm going to start with the infants. There have been 2 studies that have been completed in infants with Prader-Willi syndrome. Only one has been published. That first study, which was published, is from my friend Mette Taubert in Toulouse, France, and she showed improvements with intranasal oxytocin in 16 babies with Prader-Willi syndrome, ages 0 to 6 months, that they had improvement in suckling, swallowing, and maternal-infant bonding. So it was a great study, except for it was not placebo-controlled, so everybody got drug. And so we repeated the study subsequently, including a placebo-control arm, and unfortunately we did not find any difference between intranasal oxytocin and placebo in terms of suckling, swallowing, or maternal-infant bonding. Now, both studies had their limitations, including that they were very small. And so longer-term studies are going on with a bigger population in the EU right now. And I believe the goal for these infant studies is about 60 individuals with 60 infants with Prader-Willi syndrome, ages 0 to 3 months, with treatment going for a month period of time to determine if there are any differences between drug and placebo. And that one is placebo-controlled. So oxytocin, as I mentioned, is also used in older individuals with Prader-Willi for appetite suppression. There have been 7 studies that have been published thus far, and unfortunately the results have been very mixed. And so there were several studies that showed that oxytocin actually resulted in improvements in the hyperphagia questionnaire scores. So this is a questionnaire that was designed for Prader-Willi syndrome to assess the degree of their hunger and appetite versus placebo. But then 2 of the studies showed no superiority of oxytocin over placebo. And as a matter of fact, what you see in these graphs on the slide here is some data from Eric Hollander's work in New York that was just published this year. And what you can see in all these slides is that that placebo is actually superior to intranasal oxytocin in terms of reduction of appetite, anxiety, and OCD behaviors. So they had a dramatic reduction in hyperphagia with placebo, but unfortunately not with oxytocin. So interestingly, none of these studies have ever reported what we call overdose effects, with the exception of the first one published, which was from Stuart Einfeld in Australia, who reported overdose effects. But all the rest of them have not really reported overdose effects, but in every single one of them, a lot of patients have dropped out. And the dropouts were primarily due to what we consider to be overdose effects of oxytocin: increased temper tantrums, anxiety, paranoia. There was some people that dropped for lack of efficacy, but the great majority who dropped out of these studies did so because they were having worsening behaviors on oxytocin. So carbetocin is also being studied in the Prader-Willi community, and it is a selective oxytocin receptor agonist. So theoretically, it should not bind to the vasopressin receptors, which is what's thought to cause these overdose effects in individuals who are getting intranasal oxytocin. In recent studies with carbetocin in Prader-Willi syndrome, there was efficacy shown at a lower dose of carbetocin with reducing hyperphagia and reducing anxiety in 7 to 18-year-olds with Prader-Willi syndrome. However, there were several clinically meaningful indications that there was still an overdose seen, with several people dropping out due to increased temper tantrums or anxiety, overall worsening behavior. And so it suggests that it is still possible to overdose this drug, even though it's significantly less likely than with intranasal oxytocin. So in those with hypothalamic tumors that have been removed, that have what we in the Prader-Willi world call acquired Prader-Willi syndrome, because they develop this hyperphagia and obesity and anxiety and compulsive behaviors, just like people with Prader-Willi syndrome have. Low levels of oxytocin have been found in these individuals, status post craniopharyngioma removals, if they have hyperphagia and obesity. So if they didn't have any problems with hyperphagia or weight gain, the oxytocin levels were normal, theoretically. But what they found is that when they did an exercise stimulation test, all patients who had had craniopharyngiomas removed actually were found to have oxytocin deficiency. So you could unmask this oxytocin deficiency. So it was there in everyone, even though it didn't manifest in the same way in everyone. But it also doesn't mean that everyone would benefit from oxytocin therapy. There's definitely, it's known that there's polymorphisms in the oxytocin receptor that alter its responsiveness to oxytocin. And we also know that estrogen reduces the effectiveness of oxytocin to inhibit food intake. So it may not be as effective in young women who have had craniopharyngioma removal and are on estrogen replacement for hormone replacement therapy. So just some caveats that it may not be entirely, it may not be beneficial in the entire population. And so, the problem is that there's only been a very few case reports in patients with craniopharyngioma removal and hypothalamic obesity. And it's a very small number of patients. As Liz mentioned, Shana McCormick is doing a trial on craniopharyngioma patients at Children's Hospital of Philadelphia, but has not published the results. I believe the study is just close to finishing up. But regardless of what her results show, I truly believe that dosing of intranasal oxytocin needs to be individualized for the patients. I think that there are, as you've heard from both Ernie and Liz, there are huge potential benefits to oxytocin, including improvements in energy expenditure, glucose metabolism, and lipolysis, which are all excellent. But again, the fact is that oxytocin actually can be overdosed and cause problems. And so I think part of the problem is that people fail to think about the fact that oxytocin is one of the few hormones that has a feed-forward regulation. In other words, stimulation of oxytocin receptors causes stimulation of release of oxytocin. And so it sort of builds upon itself. So exogenously administered oxytocin may ultimately have extended effects that are sort of unplanned for. And once all oxytocin receptors are bound, if you're giving exogenous oxytocin, then it will bind to the V1A receptors, which are the vasopressin receptors. And binding to those receptors is known to cause problems with behaviors. It causes worsening behaviors like we've mentioned temper tantrums, anxiety. And so because of this, I very, very strongly believe that dosing always needs to be individualized, and that the long-term effects really need to be studied because they're really unknown at this time. And I think that's where, the field is lacking, is the ability to really do individualized dosing studies with this drug, because almost every study done to date has included sort of standardized dosing of the drug rather than basing dosing on individuals and their levels of oxytocin, because the measurements of oxytocin are quite frankly difficult to do in the blood. So that's it for me. And if you have any questions, I'm happy to answer them. And now everybody else has to come back on, and I'm going to stop sharing my screen.
Thanks so much, Jen. Thanks, Liz and Ernie as well. That's absolutely fantastic. It was a really great transition through all of the different stages, in our understanding of oxytocin. I know it was a very short period of time, but we really wanted to leave enough time to be able to answer people's questions and hopefully kind of unpack a little bit too. So the talks were really just an anchor for us to unpack this a little bit more. I didn't mention at the outset that we set this specific session up because last year at the Pituitary Brain Tumor Day, co-sponsored by CHOP and Raymond A. Wood Foundation, we just were inundated with questions about oxytocin, and we understand that there's a lot of confusion and there's a lot that, misinformation. A lot of people try to talk to their physicians about it and get nowhere because, as you mentioned, Jen, this is an experimental, research-based thing, but there are also opportunities for off-label prescribing, which is something that's common when there is a big need, and oxytocin has become more popular as one of those products that is being prescribed off-label by physicians. So the first question that we have here, I think, is a really good one, given the challenges that a lot of patients, both patients with Prader-Willi syndrome and patients with hypothalamic obesity, being on in some cases large amounts of various different drugs for all sorts of different things. These are very complex, multifaceted disorders. So the first question here is from Erin. Is there an unsafe interaction in using oxytocin and GLP-1 agonists? And I think that it can maybe be expanded out past GLP-1 agonists as well, and maybe asked, are there any drugs that we know of that these patients might be on where there could be a negative interaction with the use of oxytocin?
So I'm going to take the first part, and then I'm going to turn it over to Liz because she knows a lot more about these drug interactions than I do, I think. But nonetheless, I haven't really seen any negative interactions with any of these other type of drugs. In the carbetocin trials, at least, there were a few people who were on GLP-1 agonists, and there didn't seem to be any negative interactions that I saw. We're always very cautious because people who have had brain tumors removed and have hypothalamic obesity often are on vasopressin for diabetes insipidus, and we always are very cautious about the interaction between those two medications, between oxytocin and vasopressin, considering that oxytocin can bind to some of the vasopressin receptors. Liz, anything else that you would add?
No, I think you got it. I think the vasopressin is the one that, DDAVP, the one that I've been sort of concerned about and wanting to be careful to monitor for.
All right, was that question answered?
I think to the best that we can in a short period of time. Yes.
Yeah, a lot of this is a data-free zone, so
right.
It'll be helpful to get some studies.
I wanted to add, there was a recent paper from Jiyoung Lee's lab in 2020 that suggested when you give oxytocin centrally as well as a GLP-1 receptor agonist centrally, you might offset the effects of one another on body weight as well as on fat mass reduction. So I thought that was interesting, but I think we have to keep in mind these were given centrally, And we know that GLP-1 can act through different pools of receptors peripherally as well as centrally. And so it's hard to necessarily translate that to what happens when you give both agents peripherally. I think both compounds can act through central as well as peripheral mechanisms. So.
Agreed. Very interesting. I hadn't seen that paper.
Yeah.
Ernie. If you're ready, I can ask the second question. The second question, I think, is in reference to Liz's mention about impulse control and hedonic hunger. Question is, what other impulse control problems might be useful with oxytocin?
Well, I think that's a really great question, and there's a lot of research underway looking at oxytocin as a potential therapeutic for addiction disorders. So I think that's a big area right now. We are looking at oxytocin as a potential therapeutic in adults with ADHD. So I think based on these data, there are other conditions where it could be useful, and research is underway.
Great.
And certainly the data that you presented, Liz, showing the impact of intranasal oxytocin on activity in the VTA is relevant there. And my PhD research actually was on the role of oxytocin in addiction. So I did a lot of studies, preclinical studies of oxytocin as a novel treatment for methamphetamine addiction. And then we transitioned into alcoholism. I know the question actually was specific to alcoholism. So there's evidence there as well. We patented some of that, and there are some companies that are trying to move it forward. But there's a huge amount of work left to do.
Can I was just looking, I apologize, I was just looking at one of the questions, and somebody mentioned sublingual oxytocin. And Dean, with all of your research on oxytocin, can you speak to the efficacy of sublingual versus intranasal oxytocin?
Yeah, it's a tough one. I know that there are a number of drugs that are delivered via this route in order to improve the rapid absorption and distribution and prevent it from going through other routes of metabolism. It's my understanding that oxytocin doesn't work well in that way, and that it's broken down quite rapidly by enzymes that are in the mouth. But I also am aware of data showing that, at least in early development, very, very early development, that there are oxytocin receptors located in the mouth region. And so the oxytocin receptors are kind of there available for oxytocin to be locally applied. And I think that's very interesting, back to what you were talking about, Jen, in terms of the hypophagia in neonates with Prader-Willi syndrome. But I'm not sure how much that translates into older individuals or adults.
Yeah, it was my understanding it was broken down pretty readily by the salivary enzymes as well. And I just, again, because it's experimental, I feel like, people don't necessarily know what's good, bad, or otherwise in terms of what they're being given or what they buy, on the internet or whatever. So I just brought it up because I thought it was an interesting question. But I also didn't know the answer to.
So just to let everyone know, we have about 15 more questions. And
oh, I'm so sorry.
So, Dean, you want to ask the next one, the third one?
Yeah, no, this is a good one. I'll paraphrase this: is that we hear about oxytocin this, oxytocin that. It seems magical, but what about the potential negative effects? And we discussed a little bit here about interactions with vasopressin, but what else is there that we should be concerned about? Maybe Liz?
So, I think one issue is that oxytocin, in terms of what has been FDA approved, is for a different indication, different dosing, and that's sort of what the safety data is based on. And then, intranasal oxytocin is used therapeutically in other countries for milk letdown, and it used to be FDA approved here for that. But the doses were different. They were using much smaller doses. So I feel like, we really do need big clinical trials to determine the safety of oxytocin for this indication and at these kinds of doses to know all of the safety issues. I can tell you that what we've seen in our clinical research, and I don't prescribe this clinically, I really just use it for research. We haven't seen any serious adverse events to date. The side effects that we've seen have been mild, and they've been things like nasal irritation, headaches, nausea, and those sorts of things. So what do you think, Jen? Because you prescribe it.
Yeah, I definitely think the major thing that we see is sort of worsening of behaviors, as an adverse effect of it. I would say far and away. I mean, obviously the nasal irritation, they cough, whatever, nausea. But in terms of bad side effects, I mean, I've honestly, even though I worry about DDAVP interactions with oxytocin, I've not seen problems with that, but I still monitor very closely because it worries me, but the major thing is behavioral problems, paranoia, temper tantrums, just overall worsening of things you were trying to improve.
And can I just ask, because from a research study standpoint, one of the things that we are careful to look at is just sort of the potential for any cardiac issues, so arrhythmias or prolonged QT. Is that something that you've experienced clinically?
We have not, and I've done several of these trials, and we always watch for it too, and haven't seen any indications of that.
All right, thank you. I'm going to move us along here. So the next question is, I'm going to actually combine them because they're very similar, and they have to do with building tolerance over time. So there are a few people who are probably listening in or watching who have had their children on oxytocin. I myself have had my kid on oxytocin for 5 years. The question is, does it start to wear off over time, and is there a need for a drug holiday? And just general advice about dosing. How do you figure out the correct dose when you're treating this?
This was the question I asked the panel before we did this talk, because I don't know the answer about dosing. So I'm going to defer that one. I personally don't see any signs of, sort of tachyphylaxis or the drug sort of you becoming tolerant to it over time. But I have seen over time, because again, I always say oxytocin is a self-fulfilling prophecy. It binds to its receptors and it upregulates its own production. And so you can see overdose effects even after being on it for a long period of time, because it just maybe takes that long for all those receptors to be bound up. And so in that case, I do usually, and you know this, Eugenie, because I've said it to you before, that I sometimes, if there's a problem behavior, things are going badly, I usually suggest a drug holiday to see if that actually will reduce some of the clinical symptoms that people are having.
Yeah, and that's what we actually do that. We probably give Alex a drug holiday once every 3 months, just if we see his weight going up or if we just notice anything like that. And it's completely unscientific. It's just, hey, let's just give him a drug holiday.
Right.
Yeah.
Yeah, I mean, there's another question that came after this that we can tie in here, which is around how oxytocin is measured. And this is it was one of the challenges, is you're putting oxytocin into the system. You're not entirely clear on how long it's staying there or what it's doing, or if there's this feed forward mechanism that Jen just referred to. And certainly in endocrinology in general, I think the comment of more is certainly not better is relevant here too. So we don't know the answer to these questions is really where we're at, and it is trial and error. Measuring vasopressin, which is the sister peptide to oxytocin, both 9 amino acids, differing only by 2 of those amino acids, very similar in their weight. the receptors have cross-binding affinity with those two peptides, but the effect can be completely different. And we know a lot more about vasopressin. Really, vasopressin is also measured. There are assays to be able to accurately measure vasopressin in the blood that are used clinically and to help with diagnoses. That's not the case with oxytocin. There's not been any need to have a blood oxytocin assay available to be able to know what's going on. But certainly from a research perspective, this has been one of the things that during my times and my days in academia was one of the biggest challenges for us, is trying to track what is happening once we've put oxytocin into the system. And unfortunately, there's just not been any consistency in securing that technology to do that accurately.
So I would just mention, since this is the question about measurement and dosing, I didn't have a chance to talk about sort of the question of oxytocin deficiency in patients with hypopituitarism, and that's something that we're investigating. And it's, as you mentioned, it's challenging when you just look at a single level. But when we looked at oxytocin measurements, we took them every 5 minutes over the course of an hour in men who had diabetes insipidus. We thought were at risk for oxytocin deficiency because they lack vasopressin. And we found that levels were, in fact, lower in those patients than patients who had similar anterior pituitary deficiencies but no vasopressin deficiency, or healthy men. So we think we've identified an oxytocin deficiency in some individuals who have pituitary disease. And again, we think that those with diabetes insipidus are probably the most likely to have that. And now we're sort of starting to do studies where we're looking at different oxytocin doses. The therapeutic dose that we use for obesity, which is 24 international units, versus a much lower, more physiologic dose of 4 international units, thinking about the goal of potentially replacing this hormone in patients in the future.
Yeah, fantastic. And that's the exact type of research that needs to be done to be able to answer that stuff accurately. Otherwise, we're just guessing. So that's fantastic, Liz.
Boy, we have a lot more questions. Let me try to choose one that seems that would be of interest to a lot of people. Here's one. Let's see. Hold on. It was mentioned that there was a ubiquitous deficit in oxytocin unmasked in those with acquired Prader-Willi. I've heard that oxytocin is more effective in those with a pre-existing deficit. How are these two claims related? Does that make sense?
Oh, that's a hard question because, yes, theoretically one would say that the oxytocin should be more effective in people who have lower levels of oxytocin, and therefore, potentially there could be benefit to anyone, potentially status post-craniopharyngioma removal. But again, it comes back to what Dean just said. Oxytocin measurements are very difficult to do. The assays are not great. And so, if you look at the Prader-Willi syndrome literature, for example, you'll find that there's literature that says they have really high oxytocin levels, and yet studies are being done, some of which show that they benefit from intranasal oxytocin. So I don't know that the measurements are good enough at this point to be able to really make a link. Necessarily. Now, Liz, you may disagree with me because you've done more of that research than I have. So I defer to you on that one, but that's just my gut feel.
No, I agree. I think measurement is a major issue that we need to address in order to really advance oxytocin therapeutics clinically. And the other piece that we're working on in patients with hypopituitarism is sort of a test to stimulate oxytocin to identify this deficiency or unmask this deficiency, just like, people have a quart stim test to unmask adrenal insufficiency. We need that kind of a test for oxytocin.
That would be nice.
That would be nice.
I was going to add that from a rodent perspective, it seems like Kubliawi's lab at University of Pennsylvania, they published a paper looking at the SIM1 haploinsufficient mouse model, and they do appear to have deficiencies in PVN oxytocin expression, and they did seem to be hypersensitive to the effects of systemic oxytocin compared to wild type mice. So I thought that was interesting. Whether or not that's going to translate to the humans, I don't think we know that answer yet.
But it is interesting that they're hypersensitive, right?
Yeah.
So they could be overdosed more easily, potentially.
Yeah. I'm not sure if that means there's upregulation of oxytocin receptors.
Right.
That would be my speculation, but it's interesting because some of the genetically obese models, I think the Zucker rat, they tend to, I think, have lower levels of systemic oxytocin and upregulation of oxytocin receptors in certain adipose tissue. So it's kind of interesting.
So we're coming towards the end. We've got 5 minutes left here, and we're very aware that this could go on for a lot longer because there are just so many questions. And I think that this really should be an opportunity to open up for the community and everyone viewing now or that watch this later to be able to think about questions. And certainly that's why the Raymond A. Wood Foundation is here, is to be able to, help people with getting information that they need. There are a lot of questions about access and about referrals, and I understand that there are a lot of people spread, widely across the continent and across the world that will have questions about where they can get access to oxytocin, and then all the questions that come with that. How do I dose it? Is it okay if I am using it with other drugs, et cetera, et cetera? It's a tough question to answer, but I thought that, especially Jen, given that you have direct experience, and Eugenie maybe as well, you can chime in here and talk a little bit about, any recommendations. And I understand that, we don't want to be providing medical guidance here, but mostly just about your personal experience so people can see how it was done.
I can say something really quickly just to answer the question about how do you get a physician to prescribe, because that's asked a lot. So just FYI, I do have a page or a post on my blog, because I was sort of collecting names of physicians in the world who prescribe oxytocin, and there aren't very many, I can tell you that, but I do have. It's mostly in the States. There's a few in Canada. There's a few in Australia, New Zealand, and I think that's mostly what I have. I don't think I have anyone in Europe. But you can look at that page and see the list of mostly, American physicians that are willing to prescribe. That's all I wanted to say about my piece.
Well, and I was going to say, as you know, I am always willing to consult with other physicians if they have questions, or concerns. My number is freely out there, as is my email, if other physicians want to reach out to me. And that's how we've helped some people get on oxytocin in other areas of the country or whatever. And the other thing I would say is I personally feel very strongly that you always have to use a very reputable compounding pharmacy for intranasal oxytocin. I mean, I'm sure you could get it at any compounding pharmacy, but Harbor, the compounding pharmacy that's sponsoring this, and Empower RX are two that are FDA, approved compounding pharmacies. So they're inspected, and I feel better about those pharmacies and the safety of the oxytocin that's coming from there. That's just my 2 cents.
We had one more question, I think, that one of the members here wanted to ask, Dean. The question is about whether or not oxytocin could possibly lower the threshold for seizures. Does anyone have any knowledge about that before we wrap up?
That's a good one. That's from Marcy Sirota. Thanks, Marcy. This is a good one, and I wonder whether, Ernie, you know anything off the top of your head that you can add to this. But my understanding is that there is some evidence in rodent models that oxytocin does lower the seizure threshold. How that translates into humans, I don't know. I haven't heard reports of that. But Ernie, are you aware of any evidence for this?
It's interesting. We do see in rodent models there's a certain threshold of dosing that's sub-threshold for seizure activity, but at a high enough dose, when you give it directly into the lateral ventricle or even directly in the hindbrain, you can elicit seizures. Barrel rolling typically lasts about 2 minutes. It's interesting. We see a higher seizure actually a lower threshold for female rats than we do with male rats. This is just something we've recently discovered, but I don't know how that translates to peripheral or intranasal administration or human studies. Typically, what we are always doing is giving doses that are below the seizure threshold, so we see more specific effects on reductions in food intake. And this really just pertains to when we're giving it acutely rather than our chronic administration studies that we're looking at for weight loss.
We have one more for real last question. For real. And that is, at what age do you all recommend starting oxytocin off of the
I think that there is no answer to that question. Liz, would you agree with that?
I mean, I am I'm really using oxytocin in my research and not in clinical practice. I think it's, yeah, I don't have a good answer.
No, and I don't think anyone does. I mean, I don't think anyone knows the effects chronically if you started in a young child, you know.
Yeah.
And so I think the research just still needs to be done, quite honestly.
Yeah. Okay, I think we do need to wrap up now. Is there anything else you wanted to say, Dean, before we wrap up?
Yeah, no, I think we'll play a short video for Harvard Compounding Pharmacy after this, but I just wanted to let everybody know about our very exciting next monthly learning series with Dr. John Ragheb, who's the chief of the Department of Surgery and director of the Division of Neurosurgery at Nicholas Children's Hospital in Miami. And he's going to be talking about the use of high-intensity focused ultrasound pulsation as a novel treatment for hypothalamic and pituitary tumors. So stay tuned for that. I believe it is April 22nd that will be happening.
That's right.
Hi, I'm Mike Hua. I'm the CEO of Harvard Compounding Pharmacy. We are proud to be a sponsor for this event. We have seen hidden gems, such as our intranasal oxytocin, make life-altering changes to our patients' lives. As a company, we are passionate about research that will produce truly impactful health transformations. Our goal is to provide our physicians the tools and solutions needed to transform their patients' lives. Let us know if we can help you. Thank you for your time.